United States, sometimes patients cannot get it because their insurance doesn't pay for it, but however, they are effective. When other things fail, such as topical methotrexate or cyclosporine or Soratin or UVB light, and if the patient insurance pay, then TNFs or ILs are good choice, and we use a lot of them, and in a given patient, they do very well. Here is a summary of meta-analysis of these compounds, and most of them seem to be working well. So there are surgeons here, and I'm sure all of you are very well aware of PRP. It is very hot topic everywhere in the world right now. So here, this one study I'm quoting is treatment of male alopecia with PRP, a double-blind controlled study with analysis of platelet number and growth factor levels. This is a recent paper where they had 26 patients with androgenetic alopecia. They got 4 treatment of PRP. Either they got saline or they got PRP. And in the results, there was significant hair count, hair density, and percentage of anagen hair in PRP group when compared to the control group. And there are other papers which are talking about PRP on facial rejuvenation for wrinkles and other stuff. But if you see, most of them have like 10, 11, 12 patients. And there is really a big hype about PRP that it works. It probably does work. I also do it every now and then to my patients. But we don't know for right now what is working. Is it really the plasma? Is it the needle? Is it just the trauma itself? Because there need to be bigger, larger, studies. This is a randomized clinical trial, but the number of patients very low. If you go back to my original slide where I was showing for a class 1 study, you need large number of patients, and by large number, at least in this case, we should have over 100 patients. So I'm sure that will happen. People who are doing it, they should continue to do it. If their patients are benefited, then it's working, but there is a limitation right now, or there is no, even injection-wise, I was seeing a video of some Pakistani doctor who was using an injector, and then I have seen other people who use another injector for PRP. I have seen doctors who do like 10 injection, others do 30 injection, others do 1 centimeter apart. So there is no standard protocol because there is no standard protocol. So everybody does their own, but so limitations are there is no standard protocol, and data is not that much, and obviously cost is always the problem. Now, one of the last thing I want to talk, I have few more minutes. So when we were medical students or house officers or residents in the United States, we were checking, let's say if you're going to put a patient on cyclosporine or methotrexate, we'll do CBC, we'll do CMP, maybe check magnesium level for cyclosporine to make sure that patient doesn't get affected. But now the science has improved, and it is improving, and it's going to next step. So now we're into something called pharmacogenomics, meaning very soon, it's already happening actually, very soon, let's say if you want to give your patient a statin for cholesterol, then you may be able to test the patient for their genetic makeup to see if statin is the right thing for them. Or let's say you're going to give patient Accutane in future, then you may be able to test them to see if Accutane will work better for this patient. So, because as you all know, some patients react badly to Tylenol or paracetamol, and some people don't. Some people react badly to statins, they have bad cramps and they cannot take it, and their cholesterol level don't change much, other people do. So why is that? Because everybody has a different genetic makeup, and I think very soon there will be treatment based on your own genetic sort of makeup, and would that medication work for you or not? So we'll go into customized creams for customized patients. The last thing, as you all know, that artificial intelligence or enhanced or computer vision or machine vision is very popular nowadays, and there are a lot of work from cancer to other diseases where computers are helping humans to in treatments or in diagnosis. But my own opinion until this point is like artificial intelligence or computers or machine vision. They are basically they are helping us, or they're augmenting how we are treating our patients. But until now, I don't think they can or they will in near future replace humans, because I still believe God's machine, which humans are better than artificial intelligence so far. This was one of our paper we published. So going back, I'm going to summarize for all of our benefit, and especially young student, residents, people who are trying to write paper, their thesis. If you read a study, if you read a paper, if you're designing a study, please keep this in mind that it should be the way you read the paper, and then when you in the comment or in the summary as the paper say. So they had 10 patients, they did fractal laser before and after. There was no control site, and then 2 biopsies, and then they conclude fractal laser is the best thing for the wrinkle. It's just not in that study, it will be level 4. So when you're designing a study or reading a paper to write a paper, then look at what was the level of the study there. Was it a randomized trial with many patients or not? With that, I am happy to introduce my new textbook of dermatology, which will be released this month. And basically, this was a famous author, Mashala, who did the first few editions. I have taken it over from this year. So our first edition is now available within few weeks. And basically, it will be a 2-volume textbook of dermatology. And I'm really, really thankful to my training in Pakistan, and then my teachers in Pakistan, and everything the country has given me. Although I'm now a United States citizen and I love this country, but having a education for 300 rupees tuition fee was not possible. I couldn't have done it without Pakistan. So with that, I thank you, my team here. These are my residents, my fellows, happy mostly. And I thank you, everybody, and I'm open for questions. Thank you.